Good evening to all from India and good morning to all my friends, colleagues joining from overseas. It was one of our wish to have some webinars done with overseas participation. We are able to do in the past. Now it is Preethy's turn. Dr. Mathew, who is a regular faculty at Postgraduate Institute Chandigarh, is now on sabbatical doing visiting professorship at California, at San Francisco. And I'm so happy to get Preethy invited and consented to this program. Preethy is joined by her friend Carolina Blotte from the same institution. And from the parent institution, PGI Chandigarh, Nitin and Vighnesh are joining. Well, about Nitin, Vighnesh and Carolina, Dr. Preethy will be talking to you about them. Preethy, well, probably some of you may be knowing. Preethy, an Indian anesthesiologist working at PGI Chandigarh, is an excellent pediatric anesthesiologist. And I had been watching this young lady overseas as well as while in India, and she's doing excellent clinical work as well as academic contributions. She presented some innovations of hers at the ASA meeting 2022 and now she is there with San Francisco on a sabbatical. And today, they're delivering some lectures on some uncommon diseases where we are forced to give anesthesia. And even though they are so uncommon, there is a definite protocol to be followed in all these particular uncommon issues, which may sometimes give a problem to us. And Preethy will be starting the lecture after moderating about everybody. And I hope this lecture is going to come out successfully for all of us. Before we start, I request Dr. Jayashree to tell about the forthcoming postgraduate assembly at Delhi, as well as our annual conference, and some comments. Dr. Jayashree, please.
Thank you, Dr. Radhakrishnan. Good evening to all of you. It's a great pleasure to be speaking to all of you, an honored audience and the faculty. This is for all of you to know that the Indian College of Anesthesiologists are starting the first PG Assembly, which will be a unified called as the New Delhi PG Assembly under the aegis of the ICA. This is going to be next month, right from the 21st of July. Registrations are almost getting completed. So we are very hopeful that we'll get a few more and we may be able to adjust them. It's going to be an interactive session for the students where the students will be participating and interacting with the seasoned examiners. After this New Delhi PG Assembly, we are then subsequently in September going to have our annual conference, which will be the 15th National and the 5th International Conference of the Indian College. And this is going to be held in Lucknow in mid-September. So for that too, I request all of you to go onto our website and please kindly register. If there are any doubts, you can contact any one of us. Thank you very much. I think, Dr. Radhakrishnan, we can start the webinar.
Yeah. This postgraduate assembly, we are having the inspiration from the New York postgraduate assembly, which is there for years together. And we thought we'll also replicate the same. And we are starting this year. And I'm sure my colleagues will carry on forward with this particular program for some more years. And with that hope, I request Preethy to start the program. Preethy, please.
Yes. Thank you, sir, for the kind words of introduction about me. I also would like to, place a special congratulations to the ICA academic team, especially those who work behind the scene to organize this tirelessly and on a weekly basis, spanning over 4 years. This is very creditable, and congratulations to ICA academic team. And also special thanks to the ICA leadership comprising of you, Radhakrishnan sir, and Jayashree Sood ma'am, for this noble activity of continuing medical education for the postgraduate trainees across India. Now, coming to today's webinar, the theme is anesthesia for patients with uncommon diseases, which is very interesting. And I'm very grateful to all the 3 speakers who accepted my invitation to speak on these 3 uncommon diseases that we do not encounter on a day-to-day basis in our practice. On the panel, we have Dr. Nitin Peters as a guest speaker. He's an excellent surgeon with vast experience in both adult and pediatric surgery to cover hydatid cyst excision. On behalf of ICA, Dr. Nitin, I welcome you to this webinar. We also have Dr. Vighnesh Ashok. He's an anesthesiologist who's been trained in India, in UK, and also in Canada to speak on anesthesia for patients with sickle cell disease and thalassemia. Welcome, Dr. Vighnesh. We also have Dr. Carolina Blotte. She's a guest speaker from California to talk about anesthesia for patients with glycogen storage diseases. Welcome, Dr. Carolina, to this webinar. I also welcome the delegates or the participants who are watching this webinar. And as the session progresses, I request you all to send in questions that you have on the various topics. And we will be dealing with all those questions in the last session after the glycogen storage diseases talk in the Q&A session. Now we proceed to the first session of the evening, which is hydatid cyst excision and perioperative insights. Now, the planning and preparation for a hydatid cyst lesion excision is primarily done by our surgical colleagues, and so also is the postoperative management. And for this, we have Dr. Nitin Peters.
Yes, good evening, ma'am, and Dr. Radhakrishnan and Dr. Jayashree and all the colleagues from the Indian College of Anesthesia. Thank you for this opportunity, and special thanks to Dr. Preethy for inviting me for this. So thank you for inviting me and speaking on a topic which is quite close to my heart, and I'll elaborate on that as we go along. And I'm a pediatric surgeon, like Madam said, with some interest in hydatid disease, and I'll take you through how we manage this. So I would be talking about the perioperative insights, and specifically I would be sticking to visceral hydatid disease, especially thoracic and abdominal. I do not have experience with cerebral or cranial or ophthalmic or orthopedic hydatid, so I will not touch upon those topics. I have no financial or intellectual disclosures. Before I start, a couple of years back, maybe around 3-4 years back, we occasionally had perioperative mortality in children with hydatid disease. We still do. And that we thought of some research questions, and the Science and Engineering Research Board from the Government of India was kind enough to grant us a little research fund to answer a few of these questions. And what I want to show over here is that this was a part of the core research grant. And so the Government of India and the public health system is quite cognizant of the difficulties this disease per se has in the society. And then I'll try to answer a few of the questions, especially in the perioperative areas. So I'll look at treatment options, surgery, and anesthesia constraints in more details, and touch upon the other topics which are listed here. So around 20 years ago, there was a concept of the One Health system, and the One Health system is very, very important in today's era. It's important because it looks at the 3 factors of environmental health, animal health, and human health. And all these 3 are interdependent. So various systems of medicine have to be interdependent and they have to work together to achieve a system where zoonotic diseases are prevented and there is health promotion which is taken care of. The WHO has been working on this for the last 20 odd years. So has the CDC and the local governments in various countries. In our country, the National Center for Disease Control looks after these programs, and they're doing a spectacular job with reducing the mortality and morbidity and the public health issues of zoonotic diseases. So hydatid disease is a public health problem, and you can see that it has a very significant socioeconomic burden, and it was supposed to be eradicated till 2020. However, we still have significant number of cases in the endemic areas. We all know the hydatid word comes from a drop of water or a dewdrop, and the hydatid cysts, the daughter cysts, are actually quite beautiful. They're very, very beautiful to look at. They're caused by the larval stages of a parasite belonging to the Echinococcus genus. And children, especially boys, are quite commonly infected with this because they are more inquisitive and they're more closely associated with dogs and animals in pastoral communities. The incidence is not too much in non-endemic areas, but in endemic areas, it can be up to 200 in 100,000 population. And the life cycle is well known to everybody. I won't go into details. What you need to understand is the human is a accidental host, and it's the dead end for the parasite. So once the hydatid disease reaches a human, it's basically the life cycle is halted over there. There are various methods of diagnosis which are more or less standardized, and the gold standard for management is surgical excision. There are various species. Echinococcus granulosus is almost 97 to 98% of the disease burden. Multilocularis is seen in some Middle Eastern areas, and it's more virulent. I have no experience with this. Ogeli and Oligathrus are of veterinary interest, so I have no interest in the neck. I have no experience with the last three of these organisms. As I told you, these are essentially, this is the disease of cattle rearing, sheep rearing countries, arid countries, Mediterranean regions, Central Asia, Africa, Australia, South America, and in India, we have the Himalayan and the sub-Himalayan belt where this is quite prevalent. The overall seroprevalence is almost 15.1% in clinically suspected patients. And we are somewhere here in Chandigarh. So we have a lot of catchment areas from a lot of pastoral areas from the Himalayan areas. And we've seen that over the last few decades, the incidence of seroprevalence has gradually increased. There is a difference between hydatid disease in children and adults. What is interesting is that in children, the tissues in which the hydatid cyst grows are more elastic. The lungs are more elastic, the liver is more elastic. And so the growth of the cyst is much faster. And multi-organ involvement in children, especially lung and liver involvement, concomitant is more common in children. We do see a significant number of bilateral lung involvement. And since there is an elastic background tissue, the cysts grow and the symptoms of pressure symptoms and the symptomatic problems are much more in children. And the youngest case we've operated is just 3 years old. And because of their little not so good immunological systems, the children are more prone to perioperative anaphylaxis than adults. And we'll talk about this in more detail in the future slides. So, I won't go into details of pathogenesis, but yes, liver hydatid is common, and they can be single or multiple cysts. And the right lower lobe of the lung is the next common site in children as well as in adults. So essentially, the hydatid cyst is a disease which has a pericyst. The pericyst is an area of the tissue reaction. And the next layer is the endocyst. This is the ectocyst. This is basically a layer which kind of safeguards the parasite from the other organisms in the body like bacteria. And the innermost layer is the endocyst or the germinal layer. This is the live tapeworm over here. And this gives rise to daughter cysts. And sometimes these cysts will rupture and the daughter cysts will collect inside the endocyst. The entire endocyst is filled with a very, very antigenic, a very, very potent antigenic hydatid fluid, which can cause catastrophic problems in case it's not taken care of. during intraoperative maneuvers. This is specimen where we have a part of the lung, and you can see the same endocyst, ectocyst, and the pericyst over here. So my discussion will focus more on lung hydatid because that is more challenging to take care of surgically as well as from the anesthesia point of view. The common symptoms are cough, fever, chest pain, pneumonia, and rare symptoms can include hemoptysis. They can include a very different symptom called hydaptosis, in which some daughter cysts may be coughed out by the patient, and they may present with pneumothorax. Liver cysts or visceral cysts in the abdomen may present with pain, distension, sometimes jaundice in the liver. So this is one of the endobronchial views of a daughter hydatid, which is ruptured into a bronchus. And if you see a CT scan of a liver hydatid, you can see how the Glisson's capsule is stretched because of the high pressure cyst. And the peritoneum is also stretched. So this gives rise to very discerning pain and patients are very symptomatic with pain. Sometimes they'll come with lumps, and then that's how the hydatid is usually diagnosed. In today's era, most patients walk in with a CT scan or an MRI. So, the algorithm of doing various investigations is kind of lost in today's world. But these are incidentally looked at. If you look at plain X-rays, you can see nice round cysts which can be seen. CT scans like this can be very worrisome to the surgeon and more worrisome to the anesthesiologist who's going to be doing the case. And of course, we have patients coming in with MRI lungs with quite characteristic daughter cysts and endocysts which can be seen. There are various signs. I won't go into details. The meniscus sign or the air trapping sign seen in lungs. The water lily sign, which is the classical sign when the endocyst will rupture and fall inside the fluid or the hydrated water, and it floats like a water lily. So these are very classical signs we see on radiology. What is important is that the WHO has given a classification, CE1, CE2, CE5, and CE is cystic echinococcus. CE1 to CE3B are active stages, and CE4 and 5 are inactive stages or dead cysts or calcified cysts. So we don't really worry about these CE4 and CE5 other than surveillance. And CE1 to CE3B is something we need to take care of. So in essentiality, in clinical practice, we need to adhere to this classification. Otherwise, we don't know which cyst to treat and which we don't need to treat. And radiology is quite classical, and it is pivotal for diagnosis, staging, and it can help us predict complications also. And having said that, careful consideration for various differential diagnoses, like maybe a liver cyst or something like a mesenchymal hematoma. We've got that wrong once we opened up thinking it's a hydatid, it turned out to be a mesenchymal hematoma of a liver in a child. So, you can have these problems. And so differential diagnosis should be sorted out before the patient has come to the operating room. We have various examinations and investigations, which I won't go into details. We commonly do a hydatid serology, and it is positive in around 70 to 75% of cases in our series. So if we go back to the radiological classification, the green ones, the dark green ones are the areas which can be treated medically. And this is true for adult population, maybe not true for the pediatric population. I'll tell you why in a bit. The red ones, which is this, which has a smaller cyst, which is single unilocular, or you have one membrane floating around, can be amenable to something called pair technique, and I will talk about the pair technique. The rest of the cysts, usually the larger cysts and multiloculated cysts, need surgery. And the calcified cysts can be waited and you don't need to do anything. So certain absolute indications of surgery in our practice is that very large cysts with more than 10 centimeters in adults and say more than 7 centimeters in children. But this is from our own personal experience. It's not mentioned anywhere per se in the literature. Cysts in the left lobe of the liver, because the left lobe has less space to grow and that will cause more symptoms. Lung lesions should mostly, unless it is a contained rupture which has fibrosed, a lung lesion needs to be always operated. Any life-threatening symptoms like hemoptysis or pneumothorax, obviously you need to take the child in. or take the patient in for surgery, and patients who are symptomatic even after 3 to 6 months of medical management. And we do get a significant subset of these patients. Then there are certain soft indications, and this is because these are pastoral communities and we deal with the Himalayan and the sub-Himalayan regions. So distance to healthcare, how far the patient has to travel, geographical concerns like whether he has to cross a high mountain pass, whether he has a vehicle to go to the hospital. And in children, obviously, there are educational concerns. Children who are in important classes, like maybe high school or class 10. So you need to get over with this quickly, because they don't need to spend too much time in the hospital. It's a benign disease, essentially, but which can have very, very serious effects if not treated properly. So poor surgical risk patients or disseminated disease or less than 5 centimeter cysts, we can obviously try medical therapy, which is the simple albendazole. And this helps to decrease the intra-op fluid spillage also. Having said that, it should not be given in lung Hydatid, and I will tell you about that in the next few slides. Some people started just 3 to 4 days before surgery, but we try to give a regimen of around 1 month before surgery, if it is possible, if the symptoms are not too severe, so that the spillage and the anaphylaxis becomes less severe if it happens. So albendazole needs to be given with the fat-rich meal, and that increases the bioavailability. And it should not be given in lung lesions. The reason is that the lung lesions are more prone, they are thinner lesions, and they're more prone to rupture once the daughter cyst starts dying inside due to the albendazole once it reaches the tissue. So there may be rupture of the lung cyst after giving albendazole. So the lung cyst needs to be taken upfront for surgery. So the pair is a technique which is mostly done by our colleagues in interventional radiology, which stands for the puncture, aspiration, injection, and reaspiration. So essentially, first a cross-sectional imaging is done, the diagnosis is identified, and correctly, you ascertain the diagnosis. Then you use a Seldinger technique and do a cystogram. And once you puncture the cyst, you aspirate all the contents. After aspirating all the contents, a scolicidal agent. A scolicidal agent is a chemical agent which kills the daughter cyst. Commonly used scolicidal agents are 3% sodium chloride, 20% sodium chloride, and 10% povidone iodine or betadine. And there are many others like alcohol and so many other things. So these are the commonly used, which we use clinically. So once we aspirate and there is no bile or any other content, then we put in the scolicidal agent, wait for at least 20 minutes and re-aspirate. And at the end, do an ultrasound to see how the cyst has collapsed. The pair is a good technique for the CE1 or maybe CE2 sometimes. However, the risk of anaphylaxis, the risk of hydatid fluid spill is more in pair because it is not as well controlled as an open surgical or a laparoscopic surgical procedure would be. So when we take the patient for surgery, there are a few things which I know everybody in this audience knows, but I thought I'll just put them down because these are small things in the checklist which are very essential. Obviously, we do a detailed informed consent. We arrange for an ICU bed and a ventilator backup for all patients because we don't know which patient is going to go in for an anaphylaxis if they do. And all the drugs and all the crash cards need to be ready. The most important thing, which I think, we all know it should be done, but I'm stressing on it that we need 2 suction systems, one for the anesthesia team and one for the surgery team. And you should ensure, I usually even keep 3 sometimes if one doesn't work properly, because these are life-threatening issues in case you have spillage. So 2 suction systems are important. Adequate scolicidal. Now I'll talk about adequate scolicidal when I talk about liver and lung, the correct scolicidal, I mean. And we have an aspiration system, which is a very simple thing. It's a large bore needle with a 3-way and an IV set, which is connected to a kidney basin. So that IV aspiration system is used to aspirate the hydatid fluid. And all members of the team have to wear proper protection, especially the eye protection has to be there. When we are inside the liver or inside the chest or inside the abdomen, what is essential is very, very gentle handling of the cyst, packing of the pericyst area with the correct scolicidal agent. So we like to use 3% NaCl in children or 20% NaCl. The reason for this is that povidone iodine itself may be an irritant. And povidone iodine, when put inside the liver, can mask bile. So you don't know where the bile leak is coming from. So we do not put scolycidal like povidone iodine inside the liver. At least in our practice, we don't do that. And for NaCl, we use it liberally in the lung because we've seen patients with chemical pneumonitis with betadine and betadine spilling into the other lung through an air leak. So, these are problems which had to be anticipated and taken care of. When we are taking care of the lung hydatid, when we're doing the cyst aspiration specifically, we ask our colleagues on the head end of the patient to increase PEEP so that at the time of bronchial manipulation, what happens is that there would be some air leak. Almost in 90% of lung hydatids, 95% there would be air leaks. And there should not be a gush of the hydatid fluid into the air leak, into the bronchial system, and it should not spill into the other lung. It is a known complication and it is one of the most dreaded complications. Here, the anesthesiologist, like our team, is extremely, they're very experts in this. You should know timely endotracheal suctions and manage the air leak in the same way. So that is something which comes with experience, which we brilliantly, our anesthesiologists do, and we don't have major problems in this aspect of the handling of lung hydatids. So just a representative diagram, this is a biliary channel. This is the liver representative diagram of the liver hydatid, a biliary channel and a fistula over here. The light blue and the dark blue part is something which we are aiming to take out and close this fistula. So what we need to do is, you have some layers, you have the Glisson's capsule, you have the peritoneum, and just outside that we pack with gauze pieces or large laparotomy sponges with normal saline and with 3% NaCl in children and 20% NaCl in adults. The system which is used for aspiration should be a wide bore system. It should have a very, very wide suction, low pressure suction system, which can quickly aspirate because these cysts are tense. If you puncture it and there is no outflow, there is going to be spill of the fluid and then catastrophe can occur. So I have two videos and one of them was not working. So I'll see if, just a minute, sorry. Yeah, this is still not working. So we'll just stick with this. So this is one of the lung hydatids and it was an infected case where, the endocyst is coming out piecemeal. And this is commonly a problem we see in children who are infected, who have got recurrent pneumonias. Once we remove the endocyst, then there is air leak which needs to be looked at. I will show that air leak business in another case, which is a little better video. This was a patient operated just 2 weeks back actually, a 10-year-old boy with this cyst in the fissure of the right lung with this air fluid level. So there was a proper communication, but it was a contained leak. So we went in thoracoscopically for this patient. And once we opened the fissure, we saw that the leak was a contained leak. And I can just forward it. Yes. So there we entered the cyst cavity, used an N-seal device, which is a coagulant also, and opened the cavity. And once the cavity is open, carefully we take out the endocyst without any spill and we put it into a retrieval bag. So we use simple glove retrieval bags because of the costs involved. And after we do the, after we have done the cyst excision, so in lung, it is imperative that you put in fluid, ask your colleague at the head end to do a Valsalva maneuver and to give some positive pressure so you know where the air leak is coming from. If you do not close this air leak, then there's going to be further morbidity. And then thoracoscopically, this air leak was taken care of. I've talked about the liver and we do a cystectomy with a wide bore cannula. Open the cyst, close for any leaks, biliary leaks. And in adults, it is a well-established practice to put in omentum there so that it fills out. In children, usually you do not get that much of omentum, so we just leave it open, put some gel sponge inside, and come out happily after leaving it drain. Laparoscopic hydatid of the liver is more challenging. This is a patient where you can see it was quite densely adherent to the diaphragm, and this child was also infected. Now, one good thing about infected hydatids is that the anaphylaxis gets stunted, and there is very, very little chance of anaphylaxis once we see some pus. So actually, this is the first time when the surgeon sees pus, he's happy that he's not going to have other problems of anaphylaxis in this. And most of the time, when the endocysts are infected, they will come out in piecemeal. So that's a challenge to avoid still here and there. Sometimes we deal with large liver and lung cysts together, and two of my senior colleagues have published this experience of theirs. There were two children, and we do this regularly now with a liver and a lung hydatid. The lung hydatid you can see here, and the liver has got two cavities. So they went in thoracoscopically, dealt with the lung hydatid initially, and then opened the diaphragm, reached the liver, and then removed the endocyst, and then repaired the diaphragm like you do for a CDH repair, thoracoscopic CDH repair. So we've dealt with two cavities with a simple minimal access approach, and this is very, very good. The child goes back to school very quickly, and he's discharged from the hospital also very quickly. So there are certain factors of anaphylaxis, some non-modifiable large cysts, lung disease, pediatric age group. Modifiable factors I've already discussed, the spill of the hydrotic fluid, which has to be taken care of very carefully, and preoperative inadequate chemoprophylaxis should not be encouraged. So the Sampson's criteria for anaphylaxis is what we follow, and less than 30%, more than 30% of fall in basal blood pressure in children, or less than 80/50 in adults. Allergy symptoms like wheal and flare, pruritus, or skin lesions, and of course the airway problems of tracheospasm or bronchospasm will be there, or reduced PEEP will be there. As the blood pressure would decrease, tachycardia would be there, and that's when you need to act. I won't go into details of anaphylaxis management because that is the the expertise of the anesthesia colleagues. And in some of the cysts, like we've talked earlier, you can wait and watch, but you have to make sure that you have them under surveillance for at least 5 to 10 years. 10 years is what WHO recommends, because sometimes the cysts can start growing again. So at least 5 to 10 years has to be managed. The cysts have to be under surveillance. So like I showed you, we've done a small study, and just if ma'am, Preethy ma'am, do I have a minute, or should I skip this?
I think go ahead, Nitin. No, go ahead.
All right. Okay. Thank you. So we looked at questions. We asked questions about how immunological response is there and why it is there, and we looked at various parameters of the TH1 and TH2 groups and tried to answer the questions in our practice. So we saw that most of them were rural, and the cattle exposure were there. So like I said, in children, we have a large number of lung hydatids, significant number of bilateral lung hydatids, and we have a significant number of concomitant lung and liver. We've got spleen and kidneys and other organs which are involved, even the bladder in one child. So, there are various locations of this hydatid disease where we have to manage these patients. Yeah, so 3 of our patients had problem. 1 had spillage in spite of all the precautions which I said. 2 had significant hypotension requiring ADR infusions, and 1 child with a lung hydatid. Actually, this child had a bilateral huge lung hydatid, and she had a cardiac arrest, was revived, and was taken up for surgery after a few days again from the other side. So it was a very, very testing case for the whole team, and she is well, but she had a recurrence later. We sometimes get surprises. Like I told you, we got a surprise of a mesenchymal hematoma. This 10-year-old girl was taken up as an abdominal lymphangioma. It was a huge abdomen with the CT scan reporting as a lymphangioma, and we could not really see any cyst inside, and the senior resident was operating this in the evening, and we had a surprise of a mesenteric hydatid cyst with so many hundreds and hundreds of Blotte cysts. And so, you have to be ready for surprises on table. Let's get these. Yes, so we've had complications in 3 patients. In 2 patients, we've had bronchopleural fistulas, and in 2 patients, we've had recurrence. One was a right lung disease which had recurrence in right lung, and one was a right lung disease which had recurrence in the liver. So there are problems even with the chemoprophylaxis which patients take. So there are issues, and there are still unanswered questions. We looked at tryptase. The good thing about tryptase is that it is an enzyme from mast cells, and it can kind of correlate the severity of anaphylaxis. And we've seen that patients who had certain hemodynamic instability had higher tryptase levels. So there may be some correlation. We are still working on the detailed analysis. The other factors of IL-2, IL-6, interferon gamma did not give us major insights, and neither did IL-4 and IL-10. All patients underwent wet mount microscopy. We looked for protoscoliosis. We looked for hooklets on light microscopy. And we did DNA PCRs. We took the mitochondrial COX-1 gene and did the PCR on all these patients. And a lot of them were positive, but few were negative in spite of all clinical features of the hydatid disease. Another aspect of our study was that we looked at the circulating cell-free DNA, and we measured the circulating cell-free DNA at the time of cyst aspiration. And we could see that in some patients, we had a significant amount of circulating cell-free DNA. And I think this opens areas for future research on how to manage the anaphylaxis, how to manage recurrence in the cases of hydatid disease. And we've done some molecular work, and we've tried to type out where the hydatid disease comes from. We've seen camels, yaks, cattle, which includes buffaloes, cows, goats, sheep is common. But yak was there in one of our patients from Ladakh. So we do look at we blast the sequence through the NCBI library and get answers on what is the identity of the hydatid disease. So even out of the OT, there is a significant amount of work which needs to be done on hydatid disease, and which there are many more questions which need to be answered for this disease. So to conclude, children and adults present differently in hydatid disease. Like I told you, commonly see lung and liver in children. And what is required is a conservative surgical approach. So this term is something which mostly aggressive surgeons won't agree with, but you don't need to be radical in this surgery. You need to be very controlled, very gentle. There should be no spill or very minimal spill. And these are the things which will lead to a good outcome. And, like I told you, sir, further studies are warranted to study the role of immunological markers of anaphylaxis and disease recurrence in hydatid disease. So this is another video from one of the treks I went to. I want to thank my colleagues, I would like to acknowledge the hard work of my colleagues, Dr. Abhishek, who's a parasitologist, Ms. Simran, who's a research fellow with us, Dr. Ramya, senior resident. And none of this would be possible without the wonderful pediatric anesthesia unit, which has supported us in managing these difficult cases all throughout. And of course, without the nurses, none of us would be anywhere. So thank you to everybody, and thank you for this opportunity. I would be happy to take questions.
Thank you, Nitin, for that fantastic talk and summary of hydatid cyst. And we're so glad that you could share your insights regarding research also, including the recent advances. Fantastic work, Nitin. Yeah.
Thank you, ma'am.
Moving on. We'll move to the next session now, which is anesthesia for sickle cell anemia and thalassemia, which will be dealt by Dr. Vighnesh. So Dr. Vighnesh trained in PGI Chandigarh, followed by he went to UK and trained and completed his FRCA, And subsequently, he came back to PGI as faculty and again went on a fellowship in obstetric anesthesia to University of Toronto. His areas of interest are obstetric anesthesia, pediatric anesthesia, and global health. And he's widely published too. Over to you, Vighnesh.
Thank you so much for that kind introduction, ma'am, and thank you to the organizers for having me here today. So, yes, so I will be starting my presentation on sickle cell anemia, thalassemia, and its perioperative concerns. So, we all know that the normal adult hemoglobin that's designated as hemoglobin A is actually a tetramer that's composed of two alpha chains and two beta chains. The sickle cell mutation is actually a point mutation that occurs on the short arm of chromosome 11, where glutamic acid is replaced by valine in the 6th position of the beta chain of the hemoglobin moiety. So when that happens, we have an abnormal mutant protein that is produced that is designated as HBS. So this condition is actually inherited as an autosomal recessive state, and there is a significant degree of polymorphism as well. And polymorphism refers to a condition where the same genetic condition will present differently phenotypically, depending on how much load of the genetic mutation exists. So when the condition is inherited as a homozygous state, it's called HBSS and it's called sickle cell disease. So sickle cell disease is otherwise referred to as sickle cell anemia. So throughout this presentation, I'll be using the terms interchangeably. When it's heterozygous, it's designated as HBAS and it's called a sickle cell trait. So these patients actually have virtually no symptoms of the disease itself. So the key feature, the pathophysiology of sickle cell anemia is the abnormal polymerization of the HBS that occurs inside the RBC, induced by low oxygen tension and hemoglobin deoxygenation. So the polymers of HBS, when they clump inside the RBC, they induce distortion in the RBC membrane and cause structural membrane damage as well, resulting in what we refer to as sickling. So these sickled RBCs are actually increasingly fragile. They have altered rheological properties, as in how they behave in terms of flow in the microcirculatory level. And they also have enhanced adhesion. Now, adhesion both to each other as well as with the endothelial glycocalyx. So this results in RBC stasis, clumping, lysis, and an inflammatory response. So the normal lifespan of an RBC is about 100 to 120 days. In sickle cell disease, it's reduced by 1/10, resulting in a state of baseline chronic hemolytic anemia. Now, over this baseline chronic hemolytic state, you can have triggers which can precipitate an acute hemolytic episode, which is referred to as sickling. So now, as perioperative physicians, the background chronic hemolysis is not something that we can really change anything about, but what we can intervene to prevent is identify these triggers for an acute sickling crisis and take active measures to prevent them from occurring. So there is a list of triggers, and it's quite obvious that many of them are interrelated. Like, for example, cold can lead to vasoconstriction and venous stasis. Hypoxia often leads to acidosis. Infections often are accompanied by inflammation. So when you have dehydration, you can have vasoconstriction as a compensatory response and increased blood viscosity. So now all of these are some of the triggers that can precipitate an acute sickling crisis in these patients. So the preoperative assessment of these patients is important now because research has shown that studies done in patients with sickle cell disease are associated with higher perioperative complications. And the main reason for that is vaso-occlusive crisis, acute chest syndrome, postoperative infections, and congestive cardiac failure. Now, these four components are the most important causes of perioperative morbidity and mortality. Now, these patients can present for unrelated surgeries, but it's also important for us to understand that they can come for surgeries specifically due to the pathophysiology of the disease itself. So when you have chronic hemolysis, it can result in the development of gallstones. So these patients can come for cholecystectomies. Then you can have splenic infarcts, which can occur as part of the vaso-occlusive crisis itself. So they might require splenectomies as well. And the generalized thromboembolic nature of the condition can result in them presenting for surgeries, including pulmonary thrombectomy and peripheral arterial revascularization procedures. So the goals of preoperative assessment is to medically optimize these patients for surgery, perioperatively assess them for risk, design a suitable anesthesia plan, and plan for postoperative analgesia as well. So also as part of the preoperative assessment, we need to ascertain the genotype because that would determine how severe the disease would present as. The baseline steady state hemoglobin and hematocrit concentration is also important because now that would give us idea about when to transfuse these patients. The frequency, severity of vaso-occlusive crises and triggers, because some of these triggers are actually individualized, like some patients are triggered by certain factors. So it's important for us to know what can trigger these patients. And many of these patients actually have baseline chronic pain. And many of them, particularly in the Western world, will use home opioids. So they're not technically opioid naive. So it's important for us to identify them in the preoperative assessments as well. And some of these patients will have histories of blood transfusions that can have important perioperative concerns. Now, as anesthesiologists, cardiac and pulmonary dysfunction is what is most important for us. And these patients, surprisingly, can actually have a range of cardiac and pulmonary diseases. So they're more susceptible to mitral valve prolapse, conduction blocks, left ventricular and right ventricular hypertrophy, and congestive cardiac failure. And then in the pulmonary system, they can have acute chest syndrome, fat embolism, pulmonary thromboembolism, increased susceptibilities to community-acquired pneumonias, and pulmonary hypertension. Now, since this condition itself is quite rare, we don't have guidelines or protocols to, to test more information about how to test these patients from a cardiac and a pulmonary perspective preoperatively. So all the decisions that we take preoperatively is individualized. It depends on the patient, the kind of the surgery that they are going, and most importantly is if any of our interventions and assessments in the preoperative period would actually affect the management strategy. So the overarching theme for anesthesiologists is to prevent the occurrence of any of these known triggers so that you can avoid a sickling crisis, which has a significant morbidity and mortality in the perioperative period. So anxiety, as I mentioned earlier, is an important risk factor. So we take measures to reduce preoperative patient anxiety through patient education, counseling, and an individualized use of anxiolytic medications. Again, dehydration is another risk factor. So we must ensure that patients are not prolongedly fasted. So allowing clear fluids up till 2 hours before surgery is quite reasonable. And in patients who are undergoing major surgeries with anticipated large fluid shifts, intravenous preoperative hydration has also been recommended. And prehabilitation is a concept that's coming up now, and it's very important. And incentive spirometries has been recommended as a way to reduce atelectasis and acute chest syndrome in these patients. Now, while all of this information is clear, what remains controversial at this point of time is the role of preoperative blood transfusion, because a lot of studies have been done, many of them retrospective, and they have looked into the pros and cons of transfusing these patients. So we still don't have any concrete data about what we need to do, but most experts would recommend to maintain the hemoglobin of these patients at or slightly below 10 grams per deciliter, because 10 grams per deciliter represents the level of hemoglobin which has the most optimum sort of balance between rheology, that's like the blood flow, the blood viscosity itself, and the oxygen carrying capacity of blood. So in patients who have a higher hemoglobin than this but would require transfusions to reduce the sickle load, they could be candidates for an exchange transfusion, either complete or partial. So intraoperatively, in the absence of any outcome studies, like general anesthesia and regional anesthesia is safe in these patients, provided that it's done well with an attention to detail. Fortunately, there are no anesthetic drugs that can actually trigger sickling, so all of them can be used safely. So hypothermia is an important risk factor, so we take active measures to reduce hypothermia in the perioperative period with the use of warm fluids, bear huggers, and keeping patients covered. Now, adequate intraoperative hydration is something that's easily said but more difficult to do, because dehydration in these patients can cause a sickling crisis, but excessive hydration has been shown to increase their risk of atelectasis and acute chest syndrome. So there's no data about how to achieve this adequacy in the intraoperative period, but I think some form of goal-directed fluid therapy would be reasonable. Also, these patients are increasingly susceptible to infections, particularly the encapsulated microorganisms like Haemophilus influenzae and pneumococci. So strict attention to intraoperative asepsis, preoperative use of vaccines, and intraoperative use of antibiotics to prevent surgical site infections is also important. Now, this condition, sickle cell disease, is like right from the MCQ days, it's always been considered as a relative contraindication for the use of arterial tourniquets in orthopedics and plastic surgery as well. So while we know that hypoxia can actually trigger a sickling crisis, there's no role for routine oxygen supplementation in case of patients undergoing surgery under regional anesthesia. However, when patients receive general anesthesia with controlled ventilation, it's important to avoid hypoxia, hypercarbia, and metabolic acidosis. So post-operatively, the management of pain in these patients is actually challenging. And again, like I mentioned earlier, in the Western world, patients are not opioid naive. So we need to take into account this factor when we prescribe painkillers during their hospital admission. So analgesia in these patients is typically multimodal with the liberal use of regional anesthesia techniques. And also simple principles like keeping patients propped up, supplementing oxygen, encouraging incentive spirometry, deep breathing exercises, and early ambulation has been shown to be critical factors responsible for the reduction of the risk of development in the immediate post-operative period. This condition, this disease state is also hypercoagulable. So these patients have an increased risk of both arterial and venous thrombosis. So some form of DVT prophylaxis would be needed. And the decision whether to choose pharmacological or non-pharmacological will be again individualized depending on what the patient needs and the overall DVT risk depending on the surgery that the patient is undergoing. So when we come to thalassemia, now both of these are clubbed together, but actually the two conditions are quite different. Now, while sickle cell anemia is actually a more like a qualitative defect, thalassemia on the other hand is actually a quantitative defect. So you have two conditions called beta thalassemia and alpha thalassemia. So in beta thalassemias, there's reduced or absent beta chains with an excessive production of alpha chains, whereas in alpha thalassemia, the reverse happens. So in either of these conditions, what happens is that the excessively produced globin chains can precipitate within the RBC, again leading to abnormal membrane stability of the red blood cells, resulting in chronic hemolysis. So both the varieties of thalassemia are actually inherited as autosomal recessive conditions. And because they are like affected genetically by multiple alleles, they can present as a spectrum from trait to minor to intermediate to major. Now, patients with thalassemia don't have acute hemolytic episodes in the form of sickling. So the symptoms that these patients have is primarily due to varying degrees of underlying chronic hemolytic anemia, recurrent blood transfusions, and complications associated with blood transfusions itself, including iron overload. Now, iron overload has become markedly less common these days with the use of iron chelating agents. But despite the best use of iron chelating agents, many patients with thalassemia, particularly when they reach adulthood, often have some degrees of subclinical iron overload. So when we look at the perioperative concerns, I've taken the liberty to make a table because otherwise we would run out of time. So if we look at individual systems, in the cardiovascular system, these patients are increasingly susceptible to myocarditis, pericarditis, conduction abnormalities, and all forms of cardiomyopathy. That is dilated and hypertrophic and restrictive. And they can develop pulmonary hypertension as well, usually as a consequence of lung fibrosis and restrictive lung disease. So when we look at the preoperative evaluation, it's again individualized. We take into account the functional status of the patients and get a baseline investigation in the form of an ECG, 2D echo, blood gases, chest X-ray, and pulmonary function test is sort of reasonable. More advanced cardiac testing in the form of a cardiac MRI would be again more individualized based on the patient. Now, these cardiac and respiratory disorders can actually have important implications perioperatively. So again, we don't have data about the benefits of one form of anesthesia over the other, but the general consensus is that whatever you do it well. They could benefit from invasive monitoring as well. And these patients, particularly those with advanced lung fibrosis, could have a possible need for post-op mechanical ventilation. So that's something that we need to plan for as well. Then the renal system, there's actually infiltration of iron into the kidney itself that can actually affect how glomerular filtration occurs. So it can result in increased creatinine clearance, proteinuria, and increased renal excretion of polyvalent ions. Like generally, sodium and potassium is not affected, but the bivalent ions such as calcium and magnesium and the trivalent ions such as phosphates are actually lost in urine. So dyselectrolytemia is quite common in the perioperative period that needs to be picked up preoperatively and also managed proactively in the intraoperative period. So Again, like I mentioned, there's chronic hemolysis and anemia and a hypercoagulable state as well. So full blood count and coagulation parameters are mandatory before surgery. And this is also important for us to take more individualized decisions regarding transfusion. So there have been some case reports where cells which has been used intraoperatively for major surgeries in patients with thalassemia, and they have found that it reduces the amount of blood loss and the transfusion rates intraoperatively. And again, thalassemia is a hypercoagulable state, and these patients would definitely require some form of DVT prophylaxis. So in the skeletal system, these patients, because of extramedullary erythropoiesis that occurs, so you can have expansion of soft bones as well. This is particularly common in childhood and the adolescent period. So they can have deformities and osteoporosis. So these can have implications about how we position these patients during surgery, and they've been known to cause issues with the airway as well. I'll talk about it a little later in the next slide. So from the immune system point of view, these patients are generally more susceptible to infections because there is some degree of immune dysfunction. The exact mechanism by which that occurs is not understood. Again, like sickle cell disease, patients with thalassemia also have increased susceptibility to capsulated microorganisms, so Haemophilus influenzae and pneumococci. And these patients have received multiple transfusions through their life, so there's always a risk that they could have transfusion-related viral infections as well. So it's important to preoperatively test them for these and asepsis intraoperatively, particularly while doing procedures, invasive procedures, perioperative antibiotic prophylaxis, and reasonable levels of personal protective equipment is also needed. So, like I mentioned earlier, despite the use of iron chelating agents, these patients do develop eventually iron overload, and that can result in deposition of iron in the liver, resulting in hepatitis, cirrhosis, and portal hypertension. So this needs to be identified and quantified preoperatively, and we would generally avoid drugs that undergo extensive hepatic metabolism in patients with moderate to severe liver dysfunction. Now, the endocrine disturbances that occur in thalassemia, again, are due to the central infiltration of the hypothalamus and the pituitary with iron. These are much less common these days, but for completion's sake, these patients can have central diabetes mellitus, hypogonadism, primary hypothyroidism, and hypoparathyroidism as well. So these need to be actively looked for in the preoperative period, and if patients have one or more of these conditions, referral to a colleague in endocrinology would be reasonable. So coming to the airway, this is particularly important for us anesthesiologists, and these children can actually have orofacial abnormalities due to maxillary hypertrophy, and they can also have a high-arched palate. So these have implications on the ease and success of mask ventilation, placement of a supraglottic airway device, laryngoscopy, and intubation as well. So an airway management plan is essential, and more importantly, we must have fail-back plans in case we're not able to execute what we initially had in mind. So there is a certain degree of similarities between sickle cell and anemia. Both are autosomal recessive. Symptoms usually begin at approximately 6 months of age. And now this is interesting. That's because till up to 6 months of age, we generally have fetal hemoglobin, which is HbF, which is actually alpha 2 gamma 2. So the symptoms of sickle cell are not going to be there at all. Again, bone marrow expansion can occur in both these conditions because of the chronic hemolytic state, and transfusions often are important, more so in thalassemia than in sickle cell anemia. But there are also significant differences in both of these conditions. Like I mentioned, sickle cell is a qualitative defect, whereas thalassemia is quantitative. And the pattern of anemia that we see is also different. In sickle cell, both have chronic hemolysis, but sickle cell presents as normocytic anemia, whereas thalassemia is microcytic. And in sickle cell anemia, what happens is there's splenic infarcts, which are usually repetitive and chronic. So the spleen actually undergoes auto regression. So these patients can actually have asplenia, while the reverse is true for thalassemia. It can cause splenomegaly, and also a certain degree of hypersplenism can occur as well. So to conclude, both these conditions are relatively rare diseases, but patients with these conditions could present for elective and emergency surgeries. What's important to understand is that despite being a very, very focal disease of the red blood cell, these conditions are actually the pathophysiology and the way it manifests clinically in the perioperative period is typically multisystemic. So perioperative morbidity and mortality is higher in these patients, A good understanding of the pathophysiology of these conditions is essential for an anesthesiologist to ensure good patient outcomes. Thank you.
Thank you, Dr. Vighnesh, for excellent comprehensive review of sickle cell disease and thalassemia for us. Like, I know that these are uncommon diseases, but then, these are also areas where there is breakthrough research which is coming through with genetic, editing therapies. So I think, in the future, we should be seeing patients who have undergone genetic therapy probably, and it might also have an impact on the number of patients who are presenting for surgical procedure and where anesthesia would be required.
Yes.
Thank you, Vighnesh. Now moving on to the next session, which is on anesthesia for patients with glycogen storage disorders. Carolina, can you share your slide, please? Yeah. So we have Dr. Carolina Blotte, who is a faculty at the University of California, San Francisco. Thank you again to Carolina for accepting this invitation, and over to you.
Thank you everyone for having me. Been really nice working with Preethy these past few months. So we're talking about glycogen storage diseases today. So the glycogen storage diseases are disorders of the metabolism of glycogen. They are quite rare, most of them, and they're just dependent also on the where in the pathway of glycogen storage will they cut, where they will develop the symptoms. So all of them interfere with the body's ability to make glycogen or either convert glycogen into glucose. And depending on the type of enzyme that is blocked, a person can have some sort of buildup of glycogen in the liver, muscles, such as the heart, red blood cells, kidney, and other organs, which can cause severe infunction of the organism. We also know that glycogen is the body's primary source of energy, and normally glycogen will be stored in the liver until the body needs energy. Then enzymes will convert glycogen into glucose so that it can travel into blood streams as we need fuel. So we'll just review a little bit of that pathway on the next couple of slides, and we'll just focus on the most common diseases, as there are 9 of them total. The diseases have been categorized by number according to the recognition of the responsible enzyme. They're usually in autosomal recessive pattern, and the age of onset will also vary depending on the enzyme that is affected. So this is a little bit of the pathway of glycogen into glucose, just a little reminder of how our body stores it. So normally our body will store glycogen, and then when we need energy, it will be degraded to glucose by acid alpha glucosidase. When this enzyme is stored in lysosomes, when this enzyme is either not present or is deficient, as in then we have Pompe's disease or glycogen storage disease 2, and then we'll talk about the symptoms a little bit more. Glycogen also can be converted into glucose 1-phosphate. However, if the enzymes on this pathway are not present, such as glucose 6-phosphate to convert it to glucose, then we'll have von Gierke's disease, which is the most common one of all of them. And if there is also a problem in the branching enzymes from UDP to convert it back glucose to glycogen, then we'll have number 4. So it just depends on where exactly is the deficit, where we'll have a little bit of buildup of that specific enzyme. So this is the list of all the glycogen storage diseases. So we have number 1, which will be a glucose 6-phosphate deficiency. That is the most, or also known as von Gierke's disease. This is the most common one of all the glycogen storage diseases. We'll talk a little bit more about the symptoms of the most common ones in the next slides. The other one is number 2, which is Pompe disease, and that will also be a deficiency on acid maltase. Number 3 will be late infantile and adult acid maltase deficiency. There's number 4 is Core's disease, which is a deficiency in amylo 1,6 glucosidase. Number 5 is Brencher's deficiency, and then the ones from 6 to 12 are quite rare. I think like the incidence of most of them is less than a million, so they are not as common as the first 5. So we'll just focus ours and the most common ones for today. Otherwise, it will be an extremely long lecture. But we'll talk about von Gierke's disease, which will affect mostly the liver, the intestine, and the kidneys. It's a deficiency in glucose 6-phosphatase. It will cause hepatomegaly, hypoglycemia, and the tissue that will have more of the problem will be the liver. Then we'll have Pompe disease, which will affect liver, muscle, and heart, depending on when is the presentation. The problem with the enzyme is the lysosomal alpha glucosidase, and the key problems for these patients are they will have heart failure and cardiomyopathy, and they can have death in infancy, or if it's presented later, they can have severe cardio problems. Then we'll talk about myocardial disease as well, which is the second most common one of all these deficiencies, and it only affects the muscles, but it can be quite problematic for anesthesia, as they can build up lactate and have severe acidosis. So we'll start with von Gierke's disease, which is the first type of the glycogen storage diseases. Von Gierke's is caused by the defective liver and kidney glucose 6-phosphate activity, and it compromises 2 major subtypes. There is a type 1A, which is a complete deficiency of the enzyme glucose 6-phosphatase. There is, which cleaves the glycogen to glucose, thus leaving the patient with hypoglycemia and lactic acidosis. Then we have the type 1B, which is a normal enzyme activity. However, there is a deficiency of the transporter of this enzyme. So there is no translocation. The manifestations of these patients are a little milder than on the 1A. However, they're still, their presentation can be quite similar. The incidence for von Gierke's disease as overall population is 1 in 100,000. And the type 1A, which is the complete absence and deficiency of this, is more common than just the transporter, and is usually more common in patients with Ashkenazi Jewish population. So what we will see is that some patients with this type of glycogen storage disease may present with hypoglycemia and lactic acidosis in the neonatal period. However, they are more likely to present at 3 to 6 months of age with hepatomegaly or signs and symptoms of hypoglycemia, including seizures. Symptoms of hypoglycemia will appear with increased intervals between feeds. So if the baby has not been fed for a certain amount of time, for whatever reason, then the hypoglycemic episodes will be pretty severe. Sometimes these infants may stay asymptomatic and will present just with an enlarged liver and a protruding abdomen. That will be the first sign, and not have any other manifestations before that. The ones that are left untreated can even have severe manifestations, such as a Cushingoid aspect, because of complete liver failure. Sometimes the hypoglycemic episodes on these kids can also be quite severe, and the lack of glucose can cause severe damages and affect cognitive impairment and cognitive development that can create sequelae for the rest of the life. One thing that is important to mention is on the type 1B, which is the one that is the deficiency in the transporter. These kids will present with recurrent bacterial infections and severe neutropenia. So they're definitely more prone to infections. On the labs for this disease, you will notice decreased glucose. Obviously, sometimes there's a little lactic acidosis, hyperuricemia, hypercholesterolemia, hypertriglyceridemia. It's important to, on these patients, if you're suspecting that your patient has glycogen 1, glycogen stimulation that should be avoided as it increases the risk of acute acidosis and decompensation by causing a severe increase in blood lactate with little or no increase in blood glucose. Also, this a liver biopsy will be a good definite test. However, it's quite invasive. So if suspecting this disease, it's better to do some molecular genetic testing that will include the sequences of the genes that can express this enzyme and confirm the diagnosis. So what to keep in mind for this disease? In all these patients, they can have present with severe, depending on when they have been diagnosed, they can present with severe degrees of liver dysfunction. So it's important to do a thorough liver assessment and see how severe the liver impairment can be. If it's quite severe, sometimes it can affect coagulopathy and platelet dysfunction as well. So if there's no platelets due to how severe the liver dysfunction is, given desmopressin has been shown to help a little bit in the preoperative area to decrease bleeding. Also, studies have shown that in these patients, prolonged use of propofol is discouraged as it can. These patients are more prone to have propofol syndrome with increased risk of pancreatitis and hyperuricemia. So you want to be mindful about how much, if you're considering a long surgery, maybe continuous propofol is not a good idea for these patients. The next one is Pompe's disease, which is the type 2 glycogen-storing diseases, and is also known as acid maltase disease and glycogen-storing disease 2. This is caused by mutations in the gene that makes an enzyme called acid alpha-glucosidase, which the body uses to break the glycogen. So normal cell, it will be present and the glycogen will be able to break down into glucose. However, on Pompe's disease, it's not able to be broken down and it just build up in muscles. So there are two types of this disease. There is the early onset or the infantile form, which is that complete deficiency on the enzyme, or there's the late onset, which is a partial deficiency of the enzyme. It can begin as early as the first decade of life or well into adulthood when you see the symptoms of these patients. And it's usually you will just have muscle weakness, but as the age progresses, the severity of this weakness will become worse and worse, including respiratory failure, as muscles can be quite affected. And the main difference between the early onset and the late onset one is that usually the early onset will involve the heart, and the heart will be severely compromised with causing cardiomyopathy, while on the late onset presentation, it will be usually the heart manifestations are not seen. So just a little reminder, a little difference on the symptoms. So on the early onset, usually a child will present with feeding problems, who will not be able to gain weight. They will start having some muscle weakness that will also kind of keep progressing as they increase in age. There will be a severe enlargement of the heart, causing either a dilated or hypertrophic cardiomyopathy. These kids also will have severe macroglossia. There's just some building of muscle that, building of glycogen in the tongue muscle that will cause an enlargement. And they can also, because of the weakness, they can be very flippy and have no muscle tone. In the late onset, usually these kids live normal lives until the second decade of life, and then we will start progressive muscle weakness that can be either pretty fast onset, or they can be a little bit more progressive, but or they will really progress into like affect the muscles of respiration, causing respiratory failure and respiratory insufficiency. So for these disease, the main testing is just, again, genetic testing is the main and the standard of care. So you just want to check for a prevent. It will just confirm the deficiency of the enzyme activity. For anesthesia purposes, one critical perioperative airway examination is essential in determining the airway management for these patients. Parents should be asked for these kids if they have any presence of like snoring or sleep apnea, as they can be the macroglossia and the problems feeding can also cause severe obstruction in these kids. Since most of these kids will also have buildup of glycogen in the heart, a perioperative electrocardiogram and an echocardiogram is necessary to assess that the ventricular function and the degree of the left ventricular outflow tract are well in the degree of obstruction. We should also kind of avoid any myocardial depressant drugs and hypovolemia on these kids during surgery, as they cannot be poorly tolerated secondary to the elevated left ventricular filling pressures that they have. It's also important to avoid any inotropes or any afterload reducing agents, which will also worsen the left ventricular outflow tract obstruction that these kids will present with. Because they have really poor muscle tone, hypertonia and dysphagia are common in these kids, and it can also increase the risk of aspiration. So if the dysphagia is pretty severe, usually IV inductions and an RSI is recommended for these childs. Some of these kids will also have, because of the poor tone, they have sometimes increased potassium. So it's good to check some labs, especially if you're trying to give succinylcholine. It's usually preferred to give any other of the non-depolarizing agents, as succinylcholine might exaggerate the hyperkalemia. Usually these kids don't really have any hypoglycemic issues as they did with von Gierke's disease, so we don't have to worry so much about glucose. Our next one is Cory disease, which is a type 3 of the glycogen storage deficiencies. This is a deficiency in glycogen debranching enzyme, which causes abnormal deposition of liver and muscle as well. Again, it's not super uncommon. It's 1 in 100,000, and it's more common in North African people. The disease is caused by mutations in the LGL gene, leading to a deficiency in the glycogen debranching enzyme that works with the glycogen phosphorylase to catabolize glycogen. So usually this deficiency may either be in liver or skeletal muscle, or it can also just be on the liver. So this disease we present with 50% only will have liver buildup and will cause liver dysfunction. They also have microglossia, so they can have big tons, which can cause obstruction. A lot of them will present with hypoglycemia. That's usually their main presentation and symptoms, and a lot of them will come with severe ketosis because they're not really able to, they always have severe low sugar and they're not able to store. They'll have poor growth. Since most of this buildup happens in the liver, they will have hepatomegaly and severe liver dysfunction, including like severe liver failure. It can also store in cardiac muscle. So these kids can also have moderate to progressive myopathy, which most commonly being hypertrophic cardiomyopathy. Unlike the other disease, Cory's disease, sometimes the enzyme activity can improve with age. So sometimes these symptoms can actually become a little bit better as the kid grows, unlike the other diseases in which is like much worse with age. And then we also want to assess for coagulopathy because it depends on the severity of the dysfunction. So again, for our anesthesia considerations on this thing, you want to make sure that you have a pre-op echo and a pre-op EKG, especially to assess the degree of cardiomyopathy that these kids can have, as this can impair, like I said, what agents you want to use, similar to what we saw for Pompe's disease. It's because these kids can present with severe hypoglycemia. Pre-op admission is usually recommended, so they cannot be NPO for prolonged periods of time without any IV fluids containing sugar. So usually these kids should be admitted the day before any procedure and be on a dextrose infusion just to avoid any severe decompensations on or hypoglycemia or ketotic episodes. Liver can be severely affected, so it's also important to check liver enzyme and coags just to assess per function and avoid, especially in surgeries where there can be potential for blood loss. Intravenous steroids are usually kind of contraindicated for this disease, so it's important that to just try to stay away from them. And like we mentioned, these kids have enlarged tongues and macroglosia, so it's very, very important to assess the airway and also ask for parents if they have any major obstructions, any snoring at home, or any problems swallowing, as well as the ventilation can be quite difficult in these kids. Sometimes aids such as nasal airway or an oral airway can help, but even sometimes the microglosia in these kids can be so severe that they will require interventions early on in life, as their obstruction is really quite prominent. Next, we have our type 4. This is androgen deficiency. Again, the other enzyme is the glycogen branching enzyme, which just causes a buildup of glycogen in storage. This is an uncommon form of the disease. However, it's characterized by really early cirrhosis. Some of these kids have cirrhosis early on in life, like as early complete liver failure by age 5. They will have portal hypertension, coagulopathy, hypovolemia as a result of this. So it's important for these patients to be getting treatment early on in life. If you see a kid that has androgen deficiencies, it's extremely important to assess for living function, electrolytes, and a salt blood count before they can go into the ER. These kids, as opposed to our previous kid, they will have more dilated cardiomyopathy than hypertrophic. So a pre-op echo is really important. And last in this talk, we'll talk about McArdle's disease. This results from mutation involving the muscle-specific isoform of the glycogen phosphorylase enzyme. This enzyme will play a key role in the first steps of glycogenolysis, which releases glucose 1-phosphate monomers in muscle fibers. Since this enzyme now is present as a result, carbohydrate metabolism of the skeletal muscle is affected, and energy cannot be generated from the glycogen stores in the muscle. So glycogen is unable to be broken down, and there's just a buildup of it in the skeletal muscle. So these patients will most of the time have critical episodes of early fatigue when they're trying to exercise. They'll have severe muscle pain, myoglobinuria, and then subsequent kidney failure. Most commonly, the patient will able to do some sort of aerobic exercise for like 8-10 minutes before they start having severe cramping and severe pain. If the exercise was too strenuous, it will show brownish to red urine right after exercise. They will be easily tired. Sometimes will have stiffness and weakness just really soon after starting any exercise. Most of the symptoms will appear around with this on the older infancy or early teenage years. So as when they present on kids, they just assume that they're kind of growing pains. So a lot of these kids end up going misdiagnosed for a little while until they are showing more severe signs such as the myoglobinuria. So for anesthesia, it's important that, again, these kids have need glucose supplementation may decrease fatty acid metabolism and it will produce symptoms. So it's also really important that these kids have good IV access and are given some glucose supplementation. Succinylcholine is contraindicated in this patients, as they also not only can increase hyperkalemia, but it also, the fasciculations that it can cause severe pain on the muscles and severe strain due to the polarization of it. Prolonged tourniquets, beer blocks should be avoided in these patients also because of the myopathy that it can cause. If there's any shivering, that will also cause a lot of strain on the muscles. So it's important to prevent any shivering on this patient and maintain a good temperature if possible. There was talk in the past in terms of having incidents of malignant hyperthermia in these cases. However, that's not truly accurate. However, inhalation anesthetics should be avoided in general, as most of them can cause episodes of rhabdomyolysis. Up to like 50% of these individuals are having recurrent myoglobinuria and renal failure after exposure to inhalation anesthetics. So it's better for all these kids to just do, even though there's no risk of malignant hyperthermia, there is increased risk of having severe rhabdomyolysis. So it's better to just do a total intravenous anesthetics for these childs. And again, you should also avoid steroids. And thank you.
Thank you, Carolina, for such a, you really simplified the whole complex glycogen storage diseases for us. Thank you very much. And I don't think, I have asked them, I don't think there are any questions from the audience, but just to have some discussion, I can raise a couple of points to just to make it a little interesting. So, my first question would be to you, Carolina. Like, the way I understand it is that, we have to be very careful about the glucose monitoring in these patients overall. So what kind of fluids do you think best would be for them, and how often should we monitor glucose during the anesthesia in these patients?
I think it will depend on the type of deficiency. Some of them are more prominent to have a more severe hypoglycemia than others. So for example, in patients with von Gierke's disease, they're not have severe hypoglycemic episodes. However, patients with Pompe's disease or Pori's disease, they do have severe hypoglycemic episodes. So they actually even recommend that they will get pre-admitted to get dextrose fluids. So I think any fluid with some dextrose on it, either a D5 or a D10, depending on how low the sugar is, it's probably a good idea to have as a maintenance fluid throughout the case. And I guess just normal monitoring, maybe like every 2 hours or so should be, I don't think there's any official guidelines, at least not that I come across in my research, but probably will be good depending on how good the level of how long the surgery is.
Maybe we could also look at the trends of sugar monitoring, because the family would be monitoring the sugars for these children, I'm sure.
But especially kids with Cory's disease sometimes, because their hypoglycemia can be so severe, a lot of them will have a glucose monitoring device. So,
Okay.
So that's something that kids can have, and like the families are able to monitor and track every day. So I know like I have had some patients in the OR, not with this disease, but that they have also severe diabetes or hypoglycemic episodes, so they have an implant glucose monitor where you can actually track them. So if you ask the patient to just give you their monitor, you don't even have to do that invasive pricking throughout the case. You can just track their monitor as well.
Right. Yeah. I think that's a very key point for the listeners. Yeah. And the other question I was wondering was that, these are such uncommon disorders. We don't routinely see them on a day-to-day basis. Especially in India, one might encounter once or twice in one's career. So do you recommend or suggest any, quick, reliable online resources that one can look up? Because it's very difficult to, keep this information in the head, right? So when you encounter a patient, just heads up, online quick resources one can use. Maybe like orphan anesthesia. I mean, if you Google it, maybe, I don't know, have you looked, I mean, do you know of any online resources one can kind of reliably get a summary of the anesthetic considerations for these patients?
Yeah, I think that open anesthesia is kind of a good resource. It's
Yeah.
Sometimes a little simplified, but it can be a quick one.
Yeah, I mean, especially for, the postgraduates who want to know quickly about, if in case they encounter a patient or for their exam when they can look up. So I think open anesthesia is one thing, and orphan anesthesia is also another. Orphan anesthesia net, there is a resource, I think, which comes up on Google search. So they give a nice summary of the anesthetic considerations for these rare diseases.
When I was in residency, we had something called the anesthesia toolbox, and that was also open to everyone. It was not just an institution thing. I think actually the ABA, the American Board of Anesthesiologists, actually bought the anesthesia toolbox, and they're trying to revamp it with new lectures. So that's also a good resource.
Okay. Oh, for in the US, I think this anesthesia toolbox is a good resource for us to access. I don't think we have such a resource in India. Maybe ICA can, think of it as a future venture to put all the information in one location for anesthetic considerations for various conditions. Yeah. Thank you, Carolina. We had a good lecture from you and a good discussion. Thank you. Moving on, I would like to, Dr. Vighnesh, I would like to just, kind of touch upon, what is a transfusion trigger for these patients that we usually use? I know you said the desirable hemoglobin should be 10 for the best rheology, but would you let them have a hemoglobin of less than 10 at any point of time, especially in the perioperative or during surgical procedures? What would be the...
So what they say is, obviously we won't let hemoglobin drop to values like 4 or 5, but something between about 8 to 10 is reasonable, because it optimizes blood flow, and then oxygen carrying capacity is still okay till up to 8 grams per deciliter, after which it sharply falls. So somewhere between 8 to 10 is okay. And they never recommend any hemoglobin more than 10, because that can increase the risk of vaso-occlusive crisis.
So, I mean, is 8 to 10 is where we should try to keep
You should try to be, yes.
Okay, sounds good. And what about, procedures where, is tourniquet okay for these patients, or tourniquet is not to be used in these patients?
Ma'am, I tried looking up case reports where they have used tourniquets in these patients, and I couldn't find any. But traditionally, they've always said that it's an absolute contraindication. And I mean, and there is a logical basis behind why they say we should not use it. So I don't think anybody has used tourniquets, or at least have not published work on it. So I really don't know. But I think we would not use it. Unless it's like something like a limb-saving, life-saving crush injury where you have to rapidly place an arterial tourniquet in trauma triage or something, that's a different circumstance. But for elective procedures, orthopedics or plastic, microvascular, I don't think we would still go ahead with a tourniquet.
Yeah, I think, it makes logical sense not to use tourniquet in these patients. Agreed. Yeah. I think great talk, Vighnesh.
Thank you, ma'am. Thank you.
Nitin, can I ask, Dr. Nitin, are you there?
Yes, ma'am, I'm here.
Yeah. So I was just wondering, like, are there any criteria that you surgeons use when it comes to, going for a laparoscopic versus a laparotomy for excision, or a thoracoscopy versus a thoracotomy for these lung cyst excisions? Does the size matter, or what are the considerations that you have, in choosing the approach?
Right. So thank you for that question, ma'am. So for a laparoscopy versus laparotomy, it is essentially more of a, there are two things. One is a surgeon preference, obviously. Somebody who's more comfortable with laparoscopy, that would go. What literature says and what we follow is generally giant hydatid cysts of the liver or spleen. And spleen doesn't have those many, I mean, we don't have so many splenic hydatids, but very giant hydatid cysts, which are more than 10 centimeters, generally, which have a higher chance of perioperative spill, should not be attempted laparoscopically.
Okay.
So the other thing is that laparoscopically, you may not be able to pack the pericyst area as well as you would be able to do it in an open area with this succubicidal soaked sponge. So that is one of the, I would say, a soft indication for a laparotomy there. The other, in thoracoscopy, however, there are more challenges and more algorithms to keep in mind. And essentially, if you think you will be able to manage the air leak comfortably, then we go ahead for a thoracoscopy. However, if there are multiple hydatids in the lung, and you may have to take a longer time to suture those air leaks thoracoscopically, keeping in mind the anesthesiologist's discomfort with air leak vis-a-vis tracheal suctions, you know, so those things have to be kept in mind. But bigger children with thoracoscopic approach with single cyst air leaks, you would be able to manage them comfortably. The other thing is that sometimes in when you have a pneumothorax with the CO2 insufflation, so that may alter. So, for example, when you are checking for an air leak, you need to be careful to stop the pneumothorax. You need to be careful to stop the gas insufflation, so that you can pick up the air leak. So these are small technical tricks. But essentially, I would say if you think preoperatively you would be doing a lobectomy, or you have multiple cysts where you would need more time for managing the bronchial air leaks, that would be a soft contraindication for thoracoscopy.
Okay. Okay. And if there is a pre-operative communication, that again would be...
No, so if it's a single cyst, like in that X-ray which I showed with the fissure, the cyst in the fissure, it's a single cyst. You can see the air, you can see the lamina, and you know where the location of the cyst is. You can go in and, I mean, you don't need to spend too much time in managing that air leak. Just 1 or 2 sutures would help. So I think that is one of the concerns of how you would be able to do it. And of course, again, I think a lobectomy or a very severe pneumonia or an empyema with a hydatid getting infected, that would be a relative contraindication for a thoracoscopy.
Yeah. Thank you. Yeah. I think I think we've covered all the aspects, or more, at least most of the aspects of all the 3 uncommon diseases today. I would thank each of you for taking time out for preparing and coming over and making this session very meaningful and practical for the listeners.
Thank you.
And with that note, I would hand over the podium back to the ICA, Dr. Radhakrishnan, sir.
Thank you so much, Preethy. Thanks a lot. And
Yes.
that was an excellent webinar, as Dr. Radhakrishnan said. And of course, special thanks to everybody, but especially Dr. Nitin, who took out his precious time for us. Thank you so much, Nitin. And thank you so much. Caroline is the name? Carolina and Vighnesh. Thank you so much. Thanks a lot. And good night, and hope to see you sometime. Thank you. Okay.
Thank you.
Bye-bye. Good night, Dr. Radhakrishnan.